All right, so I'd like to introduce Mei Kwong, who is, as you can see, an attorney. She's also the executive director for the Center for Connected Health Policy, which is the nationally designated telehealth resource center for legal and policy and regulations issues. I'm sure that Mei will talk a little bit more about this, but I've heard her speak before and I've known her for a while, and I'm so delighted that she was able to join us for today, because as you can imagine, she is a very busy person in this era of COVID when everyone is switching over to telehealth services. So thank you, Mei, and I'll turn it over to you.
Thank you, Karen, and thank you for having me here today. Next slide, please. As Karen mentioned, I'm an attorney, so she did my disclaimer for me earlier, but I also have to do it. My funders really like it when I do this. So just to let you know, any information I provide today is not to be considered legal advice. It is strictly for informational purposes. CCHP always recommends that if you are looking for a formal legal opinion, to seek out legal counsel. Also know that neither I nor CCHP has any type of financial interest or arrangement or affiliation with any type of company if I happen to mention them or if I happen to show a product from a company. Next slide, please. So CCHP was actually established in 2009 as a California telehealth policy organization. We're a program underneath the Public Health Institute there, but an opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through a grant from HRSA. We applied for that, we got in, and we've been serving in that capacity ever since. But we also work with a variety of other funders and partners on other projects that are maybe a little bit more specific to a certain issue or topic, rather than sort of our broader work that we do underneath our federal grant. Next slide, please. Some of the things that we do a 50-state telehealth policy report, and I'll talk a little bit more about that later. We are also the administrator for the National Consortium of Telehealth Resource Center, and we convene a group in California called the California Telehealth Policy Coalition that focuses in on that state's telehealth policy issues. Next slide, please. So I mentioned the National Consortium of Telehealth Resource Centers, and I believe Cara may have mentioned them as well. So there are actually 14 resource centers underneath the same grant program that CCHP is. There are 12 regional resource centers that cover specific states. And then there are 2 national centers. CCHP is the one on policy, and there's one on technology as well. And while we're all individual entities and we have our individual grants, we decided to use those resources the most efficient way possible. It would be best if we collaborate on certain projects, things that have scope that would impact multiple regions or had national impact. Just to make sure those resources go as far as they can, and also to have a consistency to the information and the message that was being delivered to the different audiences that were receiving them. So we decided to form this affiliation. It's called the National Consortium of Telehealth Resource Center, and CCHP acts as an administrator of that, and really all that means is we're sort of the point person where people, instead of trying to reach out to 14 telehealth resource centers, they can come to CCHP and we can get the message out to all 14, or figure out which one is probably more appropriate to answer that question. However, you still can reach out to your individual telehealth resource center. As I said, CCHP is merely there to act as a facilitator, make it a little easier if you're trying to reach multiple TRCs. But if you are trying to reach out to your individual TRC, please do so. I encourage that, especially if you are new to telehealth. They are your frontline folks for information. They can help you with program operational level questions, technology questions, and policy questions. And when the technology and policy questions get a little bit outside of what they're able to do, that's when they refer it up to the national centers. So, but really, you're safe with contacting any telehealth resource center, and that person, whoever you reach out to, if they're not the appropriate person, they will find the right person and TRC for you to get in touch with. Next slide, please. I mentioned the 50-state report that CCHP does. So we track all of the telehealth policies in Medicaid, in state law, and in regulations. And we do this report twice a year. We have a spring edition and a fall edition. The fall edition was actually just released earlier this week. So the information that you'll find in it, it's both in a PDF format as well as the interactive map that's picture is of. That's a capture of our website. We put that information, make that publicly available, and we have it in the PDF version or in the interactive map. So if you're interested in, say, Idaho, you click on Idaho and it'll bring up the information that we've been able to find for that particular state. The information is good through October 1st. And I will say that we did incorporate any COVID changes that were made permanent. But as you are probably aware, and as I'll also explain as we go through my presentation, a lot of the COVID policy changes now are temporary. That is on a different section of our website. We have a specially dedicated policy section for COVID that looks at the executive orders, the temporary changes on the federal level, etc. That's not incorporated in our 50 state. Those are permanent, solid, on the books, either in the Medicaid provider manual or on their statutes or in the regulations. The temporary COVID changes are in different section of the website. And that's just because we weren't certain what was going to be the fate of those policy changes. Next slide, please. So goals and objectives for today. So hopefully by the end of this, we'll have gone over 8 elements of existing federal telehealth policy, and hopefully, those would be new bits of information that you weren't aware of that we'll be able to cover for you. We'll discuss at least 3 common state telehealth policy changes and identify 5 potential legal and regulatory issues that could impact how you use telehealth to deliver services. So that's the goal for today, and we'll just get right into it. So next slide, please. I'm sure everybody is aware, COVID has dramatically changed the landscape of how we live our lives, but it's really had this significant impact on telehealth. So pre-COVID-19, telehealth was moving steadily along, but it still was really rather niche in the healthcare industry. Health workers, healthcare people were aware of it, they knew about it, but a lot of them weren't actually utilizing it. And then you talk to the general public, probably only a very small portion of the general public were even aware or understood that telehealth was something that existed. And they may not even have been familiar with the term telehealth. Maybe they were vaguely aware some sort of video counseling was available. So not really a lot of broad sort of widespread knowledge or awareness of telehealth before COVID-19. Fast forward to COVID-19, that's suddenly changed everything. I've been doing this for 10 years, and before COVID, I still have family members and friends who didn't quite understand what I did for a living. COVID hits, they now understand what telehealth is and also, how they can utilize it, how they can access it. And they understand what I do for a living now. So that's a good thing. So next slide, please. I've divided this up between federal and state changes. So we're going to tackle the federal one first. I will say this is very high level because there were a lot of changes. And the reason there were a lot of changes on the federal level was because the telehealth policy on the federal level was really out of date. It had not kept pace with the evolution of the technology. I usually tell people, just sort of rule of thumb, policy develops much more slowly than technology. So the policy that exists is probably about 10 to 15 years behind what the technology can do. And that was definitely what we saw on the federal level before COVID-19. States were a little different. So states were a little bit all over the place, but there were some that kept track or kept pace with the technology development and capabilities better than others. But federally, no, it wasn't particularly good. So that was why you saw so many changes happen on the federal level. It's because they needed to, because their policies for telehealth were out of date. Next slide, please. So a lot of existing telehealth policy that specifically mentions telehealth, that's directed at telehealth, really centers around reimbursement. And that's both true on the state and the federal level. And those reimbursement policies can really be broken down into 4 elements a lot of the time. So it's what, where, who, and how. So what service is covered, where the patient is located, who's the provider providing services, and what modality you're using to deliver service. So if you look at a policy, you'll see it possibly structured as something such as, I'm a Medicaid program, so I will pay for delivery of mental and behavioral health services, what services, where, when the patient's located in a clinical setting, how, when it's being provided via live video, and when it's being provided by a psychiatrist. So you'll see a lot of the existing telehealth reimbursement policy structured around these 4 elements, and that's where a lot of the changes, the temporary waivers came in. We're addressing, like, you know, the limitations that these 4 elements like had within the policy. Next slide, please. Now, a lot on the federal level, a lot of the telehealth policy that was addressed during COVID, and that exists, that specifically says it addresses telehealth or has something to do with telehealth, is in Medicare. It's the Medicare policy, again, reimbursement policy, what's covered and what's going to get paid for. Keep in mind, though, the way Medicare approaches services that are delivered via technology, they actually have two buckets for that. They have a bucket that they call telehealth, and that is controlled by what is underneath federal statute. So there's federal law that says this is how telehealth is going to be treated in the Medicare program. So it has very specific limitations there too. So that's the telehealth. And the way CMS looks at it is, well, those services actually replace an in-person service. So instead of like going in to see your doctor for an office consultation, you do it via telehealth. It has replaced an in-person service. Medicare also has a different bucket of services that use this technology to deliver those services, but they don't regard it as telehealth because in their eyes, it doesn't technically replace an in-person service. So these are tech-enabled or communication-based services. Now, why I'm spending so much time on this and why I say there are 2 buckets, even though you're saying like, but this is all telehealth. Well, not in Medicare's eye, because they've called this other bucket tech-enabled or communication-based services. They're not held to the limitations that telehealth services are held to. So they don't have those federal law restrictions that the telehealth services would. So you have these two separate buckets of how Medicare approaches technology delivering healthcare services. You have telehealth, which has a lot of limitations of federal law, which required all those waivers during COVID. And then you have technology-enabled communication-based services, where CMS has a little bit more flexibility in what they do with that. They can do things administratively, make changes there. They put up their own limitations. I'm not saying this is a free-for-all. There are other limitations to it, but they're not restricted by federal law, so they don't have to wait for Congress to give them permission to do something. Another reason I'm spending so much time on this is that this has gotten, I think, a little confused over time during the months of COVID, because the tech-enabled communication-based services, even before COVID started, it allowed audio-only phone to be used. And then when COVID hit, Medicare CMS said you can use audio-only phone also to deliver those telehealth services. So sometimes the two different buckets got lumped together when you were talking about audio-only phone. And then I was getting calls from providers saying like, I did a telehealth consultation and I only got paid $10 or $12. And I would say, how did you do it? And they said, I did it over phone. Medicare said I can do that. And I said, well, what code did you bill? And they would give me a code that came underneath this tech-enabled communication-based services code. And I said, that's your problem. You're not billing telehealth. You're billing underneath this other bucket that CMS has, and their rates are lower for those types of services. So I just wanted to clarify that, especially if there were people who were like newer to this and may not have understood the distinction, because it did get very confused. They started getting lumped together in some of the guidances that were coming out, so it could have gotten confusing. But there are, in Medicare's eyes, 2 separate buckets of services that use technology to deliver those services. Next slide. So this is just sort of a timeline, and it does not include everything they changed, but these are just some of the highlights of what they did. And as you can see, rapidly, it was like those first 6 weeks of COVID from like March to really beginning of May, where all of the policies were changing and turning over rapidly. I was telling Cara before the webinar started that I was literally at one time, it was sometime in March, I was on another webinar. I gave my presentation. The next speaker came on, who happened to be the last speaker. When he was done, and while he was talking, I was checking my emails. when he was done, I had to get on when they were trying to close out the webinar and say, excuse me, half the stuff I just told you about 10 minutes ago doesn't apply anymore. Medicare came out with new guidance. So it was changing very rapidly. It was very hard to like keep track of what was going on. Different things were going on. And then it didn't help where they were starting to like also confuse the two buckets of technology delivered services and Medicare too. So it was a very understandably confusing time for a lot of people on what was allowed and what would be covered. Next slide, please. So again, I'm just going to go through a couple of highlights here. There were like so many changes, and you can find more detailed information on our website, or I'm happy to answer questions, but I'm just going to touch upon a couple of things, and mainly like those 4 elements that I talked about earlier of like reimbursement policy. So the changes that happened were a combination of federal measures passed by Congress, bills passed by Congress, and like CMS implementing it. So it did take sort of like basically two steps for this all to happen. But basically what they focused in on were those 4 elements that I said make up reimbursement policy, because that's where a lot of the limitations were before COVID. So first one is the where, like the location of the patient. So what you had before COVID-19 with telehealth and Medicare was the patient needed to be in a specific location, both geographically and site. So geographically, they had to be in a rural area, and they had a very specific definition of rural, which like eliminated a lot of places. I'm based in California. The pre-COVID-19 definition of rural eliminated about 98% of the state of California from being eligible because of like how it was defined. That was done away with temporarily. And again, I stress these are for the most part temporary changes. So that was done away with temporarily. The other sort of patient limitation of location was site, where they're located when the telehealth services takes place. Now, COVID-19, a lot of people sheltering in place, a lot of people at home. Medicare only reimbursed for like a very narrow set and specific set of services when the patient was at home. That wasn't going to help during COVID, because if you didn't like need one of those services, you weren't going to get it. And we're talking literally about like just 5 or 6 different CPT codes. So they were end-stage renal disease services. If you were diagnosed with an opioid use disorder, and you had a co-occurring mental health issue that was diagnosed, you could get those services at home. That was essentially it. So what they did for the expansion policy was to remove the geographical limitation and allow services to take place in the home. So that opened it up. The what services would be covered. So before COVID-19, there were probably about a little over 100 different CPT or HCPCS codes that were covered if the service is delivered via telehealth. They went to, really that number is off on my slide, it should be like over 240 different codes that they said would be eligible if the service is delivered via telehealth. And if you guys may have heard, some of you may have heard, especially if you follow CCHP's newsletter or get our newsletter, they added 10 additional codes just like a few days ago to be reimbursed if its services are delivered via telehealth. And those were some cardiology type of codes. Modality. Now, before COVID-19, the only modality that CMS would cover is if it was done via live video. Unless you were in Hawaii or Alaska in a demonstration project, then you can use Storm for it. So what they did was they allowed audio-only phone to be used as a means of delivering services, but only certain services. So if you download a copy of my PowerPoint where I have that here hyperlinked, like on services, if you click on that, that brings up like all the services that they will cover. But they also have another column saying like, and these specific services and CPT codes, you can also use audio-only phone to deliver that service. But that was something new, because that actually wasn't something that they allowed for telehealth before. Now, again, those communication technology-based codes, that's a different story. They did allow some audio-only phone for that even before COVID-19 hit. But this was new, allowing audio-only phone, not allowing store and forward. So that was interesting in that they did not allow like this other modality to be used, but they did allow audio-only phone. And that was recognition by policymakers in that not everybody may have access to like video for whatever reason at home. So audio only phone may be the only means for them to like connect with their providers. So they opened that up as well. The type of providers pre-COVID-19, very, very limited. It was only about, I think, 8 or 9 different types of providers. Physicians, midwives, dietitians were on there. You did not have a lot of allied health professionals on there, like PTs, OTs. COVID-19 hits, CMS says we're opening up to like all healthcare professionals who can bill Medicare for professional services. Only for those services, though, that are on that telehealth list. So we open it up for your providers, but your service has to fall onto this specific list of about 240 codes. Talked about the different services there. Next slide, please. These were a couple other things that I thought may have some impact in what this group is doing for behavioral health. So removal of frequency limits. There are times strange frequency limits that I don't understand why they decided to do that, but they said like you can only use telehealth like so many times in a month for this in this particular case. One of the big ones was for skilled nursing facilities. They were limited to like 1 telehealth visit every 30 days. COVID hits, they're saying like, no, we're removing that. And I thought that may be of some use if you were providing a provider providing services in a skilled nursing facility. Stark laws, for those who may not be familiar with that, those are basically laws to make sure that you are not doing, you don't have some sort of financial arrangement with a provider that you know, where you're driving business to them and you guys have like worked out this deal. It's basically just to make sure there's like no sort of double dealing or some sort of nefarious dealing between like providers. These are these stark laws. There's like a lot of safe harbors, like exceptions to it. So it wasn't like an issue even before COVID-19. Usually a lot of people who are doing telehealth programs fit into one of those exceptions. But in order to help with the speed of like standing up a program, the federal government said we're relaxing some of these stark laws. And they also did that, at least in Medicare, where they were talking about HIPAA, but I'll talk about that in a moment. So they were relaxing some of these are the non-specific telehealth laws, but laws that impact the utilization of telehealth, they were relaxing those as well. And then supervision and practice top of licensures, that's kind of like the frequency limits, and like they had limitations on, you know, how you can like supervise other type of healthcare personnel and the utilization of telehealth for that. And those are just some links to some of the CMS guidances that you may find useful. Next slide. Now, federally qualified health standards. I mentioned earlier before COVID-19 that there was a very limited list of what were eligible providers who could provide telehealth services. FQHCs and rural health clinics were not on that list. So that was problematic, especially since when we were talking about COVID, they too needed to treat their patients, and they were probably, a very important factor because there are a lot of primary care services that come from them. So Congress temporarily allowed them to be that distance site provider, that telehealth provider to their patients at the home. So that was great, allowing them to be on that eligible list of providers. However, the problem with it was that the FQHCs and RHCs have never been in that position before, so CMS had to come up with like, well, how are they supposed to do it? We don't have like the guidance on how they're supposed to do it, and they kind of have different rules applied to them. We've got to think this through. So even though that was like passed in the CARES Act, it took CMS a couple of weeks for them to come out with their guidance. So a lot of FQHCs and RHCs were like, how do we do this though? We know we can do it. The law says we can temporarily, but we don't know how to like implement it. So it did take a couple of weeks for CMS to come out with like the guidance and like how they were supposed to bill and what would be covered, et cetera, et cetera. And that's the link to the guidance, and they had updated it. It came out, I think, like on April 15th or there, and then like 2 weeks later they updated it again. Next slide, please. I talked about the technology-enabled and communication-based services. For the most part, all of these existed before COVID-19. They did add on some online medical evaluation codes during COVID, but these have always been there. And this is where you see your remote patient monitoring, one of the other modalities of telehealth. how CMS approaches it. They don't think of it as it's not part of telehealth. It's this other bucket of technology-enabled and communication-based services. So these are other codes that you may be considered in, trying to provide services to your patient. I do want to say the virtual check-in codes, that G2010, G2012, those are the codes where they allowed audio only phone before, along with e-consult, but mainly we're talking the virtual check-in codes. That's where you're getting your $10 or $12. And the reason for it is because those codes were meant to be for very, very short visits, literally a check-in with your patient. So 5-10 minutes, you only get $10 or $15, whatever, very low amount for those codes. That was what was confusing, especially new providers. They were billing these G2010, G2012 codes and wondering why they were getting such low reimbursement for a telehealth interaction. Where CMS was concerned, you weren't doing telehealth, you're doing this other thing, technology-enabled and communication-based services codes. And I keep harping on this because there were some states when they said we were allowing audio-only phone, please bill G2010, G2012. They were talking about this, and some commercial payers were doing that as well. So it wasn't just CMS, it was other Medicaid programs, and it was commercial payers as well. So just wanted to caution that if they're telling you to do this and you think you're doing telehealth, you're not. You're doing what comes underneath. You're using telehealth technologies, yes, but you're not doing telehealth. You're doing probably what they view as technology-enabled or communication-based services, and you're probably going to get reimbursed at a very low rate. Next slide, please. And then this is just the guidance to FQHCs and RHCs. I've said that they have a lot of limitations. They have limitations on how they use this other type of services, the virtual communication-based services too. And they get paid. They can only use certain codes, and then no matter which one of those codes that they use or service they provide, they only get paid $24.76. So they're limited in what they can do, and they have this flat rate as well. Next slide, please. Now, these are other federal policies that happened during COVID that I thought you guys might be, this audience may be interested in, that may have impact in your practice as well. One of them was the DEA. So when you're talking about controlled substances, federal law controls. So they decide and like how that's working out when you're using telehealth. And when you're talking about telehealth and prescribing controlled substances, it is there's like about 6 exceptions where you can use telehealth, and they're mainly where the patient's located with somebody. So they're in a DEA licensed clinic and the telehealth provider is connecting in, or they're with like a DEA licensed provider at the time of the telehealth interaction. One of the exceptions that they allow is when there's a public health emergency declared. Public health emergency was declared, so you don't have to be in like that the patient doesn't have to be in that specific type of situation or type of setting. The telehealth provider can now prescribe them a controlled substance. The one other thing that they did, which was really unusual, for treatment of opioid use disorder, you can prescribe buprenorphine via phone if certain conditions are met. And it's a very specific, narrow situation that they'll allow that to happen. But that was kind of interesting to see that they too are allowing phone to be used, but only for the specific scenario. Other sort of changes that were made, I alluded to some of this earlier, where for Medicare that they were temporarily waiving like licensing requirements. There's like regulations in Medicare saying like you got to be licensed in the patient state, and they waived that requirement during COVID, but they did say like, but state law will still apply. So that kind of threw a wrench things for many people, because state laws do cover the whole licensing issue. So unless the state did a waiver, you are still going to need to be licensed or fit into some narrow exception. And then HIPAA, I mentioned earlier as well, they relaxed some of the HIPAA requirements too, but then you still have to face state law, because some states may have had like actually more stringent requirements when you're talking about protecting health information. Next slide. So there was a proposed physician fee schedule. This is an opportunity for CMS to make things permanent that were temporary, but they can only go so far. Basically, just sort of like what services would be covered because everything else is in federal statute, they need Congress to give them that power or to allow the change to be made. So they couldn't really make a permanent change there. What they could make a permanent change on is like what services that they would put on the permanent list, even when the public health emergency is declared over. So that was what they did. That we should be seeing what's finalized soon because that came out in August, and then the comment period was over on October 5th. So we should be seeing like what they are going to finalize for 2021 for the physician fee schedule soon. Next slide, please. The states. Next slide. So the states were really like everywhere as far as like their telehealth policies and Medicaid before COVID hit. But you basically had every Medicaid program reimbursing for something if it was provided via live video. Store for and remote patient monitoring, a little less popular. That's important to note, especially for remote patient monitoring, because if a Medicaid program was allowing the home to be originating site, usually they were talking about remote patient monitoring. The remote patient monitoring policies were like pretty limited. So it was very specific, such as it would be treatment of certain chronic conditions, for example. So that threw a wrench into things when COVID hit, in that there really wasn't like a lot of expansive allowing the home to be originating site when you were talking about Medicaid programs. Next slide, please. Also, states have commercial payer laws. So the majority of states do have some type of commercial payer law on their books. However, they range from a law that says commercial payers, you can cover telehealth if you want to, all the way to state laws that say commercial payers, you shall cover telehealth the same way you would have had the service been delivered in person. And by the way, you will pay the same amount. So, and then everybody else kind of falls in between. And that kind of dictated, how much power, executive order power there was by the states to like tell commercial payers what they had to do during COVID. Next slide, please. So what were some of the common telehealth policy changes on states? Really reflected what we saw on the federal level as well. Big one was allowing home to be an eligible originating site, allowing telephone to be used as a way of providing services. I mentioned before that before COVID-19, a lot of people did not regard telehealth as coming underneath that umbrella of a modality of a telehealth. But because of the situation, because not everybody has access to telehealth, they had to make that available. And then, requiring health plans to do something regarding telehealth, whether it was encouraging them or actually flat out just saying like, you will cover telehealth delivered services. They issued something. A lot of states issued something, but they were kind of varied in like exactly what they were dictating. Next slide, please. Less common telehealth policy changes, expanding to other modalities. So again, store and forward remote patient monitoring, like on the federal level, not really as expansive. I mean, there were some policy changes for some states, but not like a lot of them were doing that. The phone was a bigger sort of modality that they focused in on. Expanding the list of providers to include other professionals, such as allied health professionals. Pre-COVID-19, your allied health professionals, a lot of places didn't really allow them to use telehealth where they would get reimbursed. Expanding that, allowing them to be on that list. Again, not as popular as like the home and the phone type of policy changes, but it did happen in like, a couple of states, but it wasn't like as widespread as we saw with the other policies. And then a lot of states, more than half the states, have some sort of consent requirements when you're talking about telehealth. It's either in statute or in regulations or in their Medicaid program, making adjustments to that, such as if they had a written consent, they would allow it to be oral, or the timing of when you get the consent. Next slide, please. Now, there also, like on the state, you have other telehealth policy issues that are going to impact things as well. So you have like licensing, privacy, malpractice. There's always a concern about malpractice, consent, and reimbursement. We've talked about consent a little bit and reimbursement, but let's go into like some of these other issues as well. So next slide. Licensing. I said earlier, the feds provided some flexibility in Medicare and Medicaid, but they said state law will still apply. Not all states allow the flexibility. So for example, California, they did allow some flexibility regarding licensing, but they said that a California facility would basically have to apply to like have a provider from out of state come in to like provide services within that facility, and they didn't have to get licensed in California. Other states were a little bit broad. They were saying like, as long as you're in good standing in the state that you're licensed with, we'll let you practice here without a license. So pre-COVID-19, the licensing issue was recognized as an issue for telehealth, but it was mainly addressed through state compacts. but not all states belong to those compacts, so it was problematic. They didn't really solve the issue during COVID-19, though, and also the compacts vary in like what they did. So there's a nurse compact, which is one license from a state, practice in many states, where then you have like the medical license one, which is it's an expedited process to get a license in another state. So they didn't really quite work out for the most part for addressing the COVID issue. So that's going to be a lingering issue that's out there as well. Next slide, please. Privacy, as I mentioned, the feds may have and Medicare relax some of the HIPAA laws or relax some of the HIPAA laws, but states have, some states have more stringent laws to protect like health information. So you would have to see like, was my state a state that did relax some of those privacy protections, and some did. Some like made like platforms easier to use, or we're allowing texting as a way of like providing services in some respects, but not all of them. So again, depending on what state you were like trying to provide services into, you'll have to check to see what they allowed. Additionally, there may be state laws that are not necessarily related to healthcare or health privacy that you need to be aware of. So for example, there is in California a commercial law that says if you are providing services or goods to residents of California, on your website you need to have a phone number where somebody can reach a human being during business hours. Not related to telehealth, not related to healthcare, but can impact telehealth if you are a telehealth provider advertising services to the citizens of California. So you would need to know, like, yes, I need to, during business hours, have somebody available by phone to answer questions. Next slide. Malpractice, a lot of people always ask questions about like, well, how much malpractice is there in telehealth? And that's really hard to tell. Not a lot, but I think part of that is a numbers game. So before COVID, not as much utilization, so not as many opportunities to have malpractice claims. And a lot of malpractice claims were settled out of court. So I actually don't know a lot of details about them, because when you settle out of court, you kind of agree to not talk about the details. But what I do say is keep aware, if you are trying to provide services in another state, your malpractice insurance may not operate in that state. So check with your carrier. And also, if you're starting off to doing telehealth, your malpractice coverage may not cover those services being delivered via telehealth. So check with your carrier. I spoke about consent a little bit earlier, and then there are sometimes weird additional requirements that states may put up, such as if you're a telehealth business, they may require you to register with the state that you are. I believe New Jersey has that rule. So there may be these quirky little other rules that a state may have regarding telehealth and operating in that state as a telehealth provider. Next slide, please. Just really quickly, I'm running out of time, but I just want to point out that with COVID, we're starting to see government websites provide information for consumers. So this is something that the state of California did for consumers that had some general information on telehealth. But what was really interesting is you could, as a consumer, you can type in your zip code and it would bring up like the health plans that operate in your area and link you to their telehealth policies. Now, the information regarding telehealth policies was linked to the health plan's website, so they varied in how good that information was. They could have had something very simple, like a sentence saying like, and we cover services delivered via telehealth, and then another site could have some very elaborate, dense information such as like, yes, and we'll cover these services, this is what you pay copay, etc., etc. But it was nice to see sort of like a government entity put something out like this for the consumer for them to see. Next slide, please. And the federal government also put out some information both for patients and providers regarding telehealth and some resources that they can access. So these were two nice sites that we saw out there that we weren't seeing before COVID-19. And it also indicates to you sort of not only the interest and investment like a government may have in telehealth, but also, the effort that they're putting out there, and the possibility that this is going to stick around for a while if they put this much effort into it, at least for the federal government and for California and other jurisdictions who may have done this as well. Those were just two examples I pulled out. Next slide, please. And these are just some links to some resources that CCHP has, and I think that is about it. Next slide. I think it's just a thank you, and our website, our URL, and our an email address if you guys have any questions.